cover and coordinate the healthcare issues for AIF for the past several years, and I can say that as a Floridian, as someone who pays attention to the process as a citizen, I feel so blessed to know that someone like Dr. Kerry Pigman is a member of the Florida House of Representatives. His medical background, his military service are so admirable and honorable, as well as his intellect and insight is just amazing. And we are fortunate to have, his service and his leadership to the state. And we are thrilled to have him here today to talk about our panel on controlling costs. And with that, Dr. Pigman, I will let you take the mic. Thanks so much.
Thank you. Thank you all. I appreciate this. And I'm another one of those graduates from The Ohio State University. There seems like there's a bunch of us down here, not to be confused with any other Ohio State universities. And I want to start with an anecdote just to point out. A couple weekends ago, I was doing a night shift in the ER. It's one of these juxtapositions of your day job and the time in the State House. And there was a fellow who was being brought in by ambulance who had been out partying, as you're allowed to do. He'd been partying with crystal methamphetamine and PCP and had torn through all the restraints of EMS. So when he came in, he had 3 hulking sheriff's deputies holding him down. So when I went in to examine him, and he's screaming and shouting, and I walk up beside him, and he looks over at me and looks at my name tag and says, without breaking a sweat, he just says, "Oh, Mr. Pigman, I know who you are. I see you in the newspaper." And without dropping a beat, I turn to the sheriff's deputies and say, "Guys, take your hands off. He's no longer a patient. He's a constituent." Now, I still gave him a lot of Geodon, and he calmed down and then went home that morning. But I want to be serious for just a minute. First off, that tells you print media is not dead. He reads the newspaper. The serious thing that we're looking at is we know, as a portion of our gross domestic product, how much we spend on health care. And when we compare ourselves with other Western countries, we're struck with this lack of any demonstrable benefit from that increased spending would do. So that's one thing that's really driving things. And for many reasons, I don't think we're going to continue to get more money to do what we're doing currently in health care. And we've all had lots of very smart people tell us, and it's my anecdotal observation, that upwards of a third of what we spend in health care doesn't really improve patient outcomes, doesn't really benefit the patient. Now, you might consider that waste. It's not waste in a traditional sense because someone's benefiting from it. It's just not the patient who's benefiting from it. And as an ER doc, I may be one of those ones who benefits from a fractured healthcare delivery system without consistency and practice in the most expensive place possible. But in the State House, I'm not an ER physician. I'm a prudent payer of services, purchaser of services, representing the people who pay taxes in my district. So what this panel was brought together to talk about are the hidden cost drivers. And I think there are many. I think they're rife throughout the system. Since there's many who profit very well from those inefficiencies, those hidden costs, they're sometimes very hard to get rid of. And I think that the direct healthcare costs, which are easily documented, are in fact climbing in part due to these indirect costs, and we're all paying for it. So this panel will look into those elusive costs and challenges of defensive medicine, fraud, and overregulation. So what I'd like to do is to start with Dr. Stephanie Holliday. First off, I'd like to have you tell us a little bit about you, since I don't have their bios up here. Sorry about that. And the question that we have written down for you, and then we can go from there. Almost every day we learn of scientific breakthroughs, things that cure sickness, that alleviate symptoms, that improve our quality of life. TV and magazines are full of ads describing these new interventions. With all this advancement, what can we also expect to encounter and prepare to tackle as we move forward?
Okay, so good morning, everyone. My name is Stephanie Holliday, and I'm a pharmacist. I'm Vice President of Clinical Services for Acaria Health. Acaria Health is a subsidiary of Centene Corporation, and we are based out of right here in Orlando, Florida. Acaria Health primarily is a specialty pharmacy solution for a number of different payer, patient, and provider clients. When I say specialty pharmacy solution, I'm mainly talking about medication distribution, benefit management solutions, and also clinical services. So thank you for having me here today. And with regards to direct-to-consumer advertising, I think that there's a lot of education that patients get with media sources, whether it's on Facebook, the internet, YouTube, regular commercials. And I think something to just be aware of is that these patients not only have access to those resources, but they've also got access to primary literature, their providers, and other more scholarly resources. So with regards to managing those costs, I think it's just really important to keep that information in mind. We run into that a lot with patients, particularly with multiple sclerosis, that tend to stay ahead of the curve as some would expect with other patient populations. And so what we do at Acaria, what we always recommend is that we develop policies that are always on the cutting edge of research and technology, make sure that policies are up to date, that we have the right subject matter experts and thought leaders participating with the development of those policies.
Thank you. A lot of times there's a notion that if we just spend a little bit more, we'll get a better outcome. And we're very much impressed with the science, the technology, cutting edge, leading technologies. And unlike in automobiles and automobiles and electronics, where the price seems to come down despite those increases, how do you communicate to an individual patient this expectation that it should cost much more, it must cost much more, but yet reassure them that they're getting adequate therapy? How do we know that they're getting the kind of personalized therapy that will give them the best value and understand that that really benefits all of us?
I think just really making it a personal conversation with the patient is the way to go. Personalized medicine has really made great advantages over the last couple years, particularly when we get into genotyping and pharmacogenomics. And a lot of patients may not be aware of the different testing modalities that are in place to really appreciate if a therapy or treatment course is the best case scenario for them. So I think providing them with that information and presenting them with the outcomes that have been produced by studying those therapies in patients like themselves, it will help them, to really get buy-in into those modalities.
In other words, what you want to communicate to them is there's some therapies that might seem to work for other people that won't work for them, so there's no reason embarking on that therapy.
That is right. Definitely, it can work the other way where, a patient wants to pursue a particular agent that has not been found to be efficacious in their background type. So I think communicating that information to them is very appropriate.
Okay, thank you. Lori Shirley is a certified registered nurse anesthetist, and I'd like for you to also tell us a little bit about yourself, but what I'd like to start with is one of the repeated goals that you hear us policymakers talk about is increasing access to health care for many of our state citizens, especially those where we have existing physician shortages and probably anticipated physician shortages, especially in the rural areas, but also inner city and other places. So if you could, just kind of explain your approach to that, your observations with that, and with what we can expect, and what might be some ideas and incentives to fix that.
Well, my name is Lori Shirley. I have been an RN for 30 years, practicing CRNA. I practice in Miami. I've been working in the health policy arena for about the last 10 years as the federal political director of the Florida Association of Nurse Anesthetists, and most recently at the state level on the Florida Action Coalition. And I am very interested in access issues and better utilization of our healthcare workforce. And that is, I am a PhD candidate at the University of Miami, and my research focus is relieving barriers at the institution level to barriers to best utilization of our healthcare workforce. To answer the access question, certainly we have areas of access problems in the rural communities, but more importantly also, or just as important, in the urban areas. And we have many barriers in place to providers who are non-physicians who tend to practice more in these areas. So our critical access hospitals and our federally designated healthcare shortage areas tend to be where we have a higher concentration of nurse practitioners, all the advanced practice nurses. There's 4 types. Nurse practitioners, CRNAs, nurse anesthetists, midwives, and clinical nurse specialists. And they do tend to provide a higher proportion of care in those rural and federally qualified shortage areas.
Thank you, Lori. Could you, we often hear us policymakers that there's really no cost savings when you look about different providers. It's the same unit cost for anesthesia, let's say, per unit time. Now, I'm not in anesthesia, so I don't know how that's billed, but that's what we commonly hear. Could you describe that kind of reimbursement system and what other monies are being involved there?
There are a lot of hidden costs to how the state regulates practice arrangements. A very effective strategy that other states have used are relieving the barriers to practice that exist in state law. And the hidden costs, specifically anesthesia, are that you are paying, it is true, one anesthetic is reimbursed one amount. What is hidden is that more than one provider is being paid for that anesthetic if you're in a supervised state. And Florida is a supervised state. It's written in Florida state law that a CRNA must be supervised by a physician or a dentist. It does not have to be an anesthesiologist. And in these practice arrangements, what you see is hospitals will have to pay subsidies to be able to sustain the anesthesia department in their facilities because you're paying for layers of redundancy of practitioners. You also see hidden administrative fees, and you also see built-in inefficiencies in your systems because of the billing and the reimbursement arrangements. For instance, there's an economic report that came out in 2010 that the only sustainable model that is financially sustainable for anesthesia care delivery is a CRNA model. Now, CRNA-only model. Now, nobody is promoting that is right for every institution, but there is a variety on a continuum. You can have a CRNA-only delivered anesthetic, you can have an anesthesiologist-only delivered anesthetic, and you can have a supervision model anywhere in between where you could have 1-to-1 supervision, 1-to-2, 1-to-3, 1-to-4. 1-to-4 is the most popular anesthesia ratio of 1 anesthesiologist to 4 CRNAs. That's the most popular one found in the anesthesia care team model. And what you see in that, and that is also sustainable in high volume, very efficient ORs. But in order to bill and make that a financially viable situation, you have to meet 7 TEFRA rules that are Medicare rules. Things like being present during induction, being present when the patient wakes up, being present for the most strenuous parts of the anesthetic, being present in the post-op area. If anesthesiologists meet these 7 rules, then they can bill for 50% of the anesthetic. If you do the math, that means the anesthesiologist can make 2 times what they would make by delivering the anesthesia themselves. So this is a very popular model in the anesthesia care team for that reason. The problem is you can't be in 2 places at once, and you certainly can't be in 4. So what the outcome of this is either you decrease efficiency of your OR time, and OR time can cost anywhere, depending on your institution and the case, $40 a minute to $100 a minute. So you wait for the anesthesiologist to come before you can start the case. You wait for that anesthesiologist to come before you can come out of the room because they have to be there during the patient's waking up in order to be reimbursed for these 7 TEFRA rules and the most lucrative way. If you follow the rules, it automatically institutes inefficiencies, which the hospital pays for, the patient pays for, the business pays for, and the payers pay for. And this is a completely hidden cost. Most people know nothing about this. If you don't follow the 7 rules, then that's Medicare fraud. And we all know that the feds are really cracking down on that right now.
Thank you, Lori. Could you give us a notion of what the magnitude of this subsidy would be? And I guess as a payer for services, what should I be expecting to get in return for that dollar, even though it's a hidden cost? It's still a dollar I'm providing to the system. What do I get out of it as a payer?
Well, what you get is the anesthesia care team has the ability then to bill on the 1-to-4 medically directed model. You, as the payer of this, really don't appreciate any other value out of it. The anesthesia, that money goes to the anesthesia department or the anesthesia group who is billing in that format. Typically, in 2008, the subsidies were $140,000 per anesthetizing location per year. In 2011, that money went up to $160,000. Now, this is national averages. And we really thought with the consolidation of anesthesia care that those subsidies would come down. And the MGMA data just came out, and in 2014, those subsidies were $168,000 per anesthetizing location per year. So if you have 6 operating rooms and you cover OB and you cover GI, so you have 8 anesthetizing locations times this $168,000 per year, that's $1.3 million that is being paid for redundancy in providers.
Lori, are there other states that have a different arrangement?
Yes.
A different requirement? And if so, is there some difference in outcome? Is there some demonstrable outcome difference that would justify the $1.3 million per annual additional expenditure per average facility?
Right. No. There have been overwhelming data. There have been many studies, and we do have a booth out in the exhibit area, and I would love to talk to anybody who's interested about the outcome studies. But a very unique situation happened in 2001, where the CMS decided to allow states who had, and they were more rural and mountain states, who really had access issues. And they decided to allow the governor of those states to opt out of supervision, physician supervision for CRNA services if it met the state's needs. 17 states to date have opted out, but this set up a very elegant study where we looked at 500,000, we didn't, it was an independent Research Triangle Institute, looked at the 14 states at the time who had opt-out versus the other states who didn't, and they compared Medicare outcomes, and there was no difference in the outcomes found. It was over 500,000 patients that they looked at, and in fact, in some instances, the CRNA-only cases in that state did better. So for the most part, statistically significance is none.
Thank you, Lori. Thank you. Let's move on to Wayne Oliver. And if you could, tell us a little bit about yourself. Well, we're going to start out with litigation and medical malpractice is described as a huge cost driver for our system. And we think it's, that kind of litigation is a big threat to anyone's business, let alone health care. How does the litigation environment in Florida impact on health care costs and delivery of health care?
Well, thank you, Dr. Pigman. And first off, appreciate the opportunity to be here. There seems to be a theme running through at least the morning presentations, which is disruption and transformation. And it's a little bit about my background is I'm a recovering lobbyist. I've been described as having a senior title. I don't know if that refers to my age or how long I've been around the block, but now I have advanced to legislative terrorist. And I represent an organization called Patients for Fair Compensation, which is a part of Jackson Healthcare. And we have been examining the problems associated with medical malpractice litigation. Michelle Mello, who is arguably one of the most experts nationwide on patient safety, described the current system in 3 ways. She said, first, the medical malpractice tort system doesn't take care of the folks that it is intended to take care of. And secondly, it hemorrhages vast amounts of money in the process. And third, that it has disastrous and very painful side effects. Those painful side effects manifest themselves nationwide and in Florida in the terms of defensive medicine. We heard Craig talk about it this morning in his opening remarks. But nationwide, defensive medicine, according to Gallup, is 26% of all health care. In Florida, it's actually 34% of all health care, meaning that that's 34% of your dollars that are providing no clinical advantage, no treatment value, no diagnostic value to the patient at all. But these are merely services that are ordered by physicians to protect themselves against potential litigation. So when you say, Wayne, what is 26 or 34% of healthcare in Florida? It's a $43 billion industry that is providing no value at all to patients, but rather is just wasted resources. So there's a slide that we can throw up real quickly that I'll show or try and describe the current scenario. There we go. This is an iceberg, obviously. Above the iceberg, you see the $31 billion industry that we know as medical malpractice. That represents premiums, that represents attorney's fees, costs. It represents all of the things that we know that are associated with litigation. Below that is that $650 billion a year problem. The current system really does nothing to impact defensive medicine. More specifically, if you look at the state of Florida and compare it to, let's say, Texas, which has arguably the most robust tort reform package that's been introduced in the country. It's constitutionally protected there, but Texas docs practice the same amount of defensive medicine as docs here or in Georgia or in Idaho or anywhere else. And the reason is the litigation system. Pure and simple, doctors avoid or order all of these unnecessary tests, procedures, referrals to protect themselves against litigation. If there is no litigation, then there is no need for defensive medicine. And all you have to do, Dr. Pigman, is look around the planet to see what other countries do, and nobody practices medicine the way our doctors here in Florida do. As a consequence, our costs are higher than anybody else, but also so is the cost of litigation and its role in terms of patient stress as well as physician stress is pretty remarkable.
Thank you, Wayne. You're kind of suggesting that maybe the reason we spend 50% more of our GDP on healthcare than other countries may in part be related to that. But close the loop for me. The one thing we're missing with our current litigation environment is really improving patient outcomes. It's fear-driven. How would what you're suggesting be different from a quality of care perspective?
Well, a couple of perspectives. Number one, when doctors are focused on defensive medicine, they're checking off a list of tests, procedures, referrals that they are going to perform, as opposed to paying attention to that specific patient and their needs. So they're distracted because of defensive medicine. But also, you know, when we're in an environment where doctors can't talk about medical errors in an open and free manner because they're concerned about landing in the middle of a lawsuit, we're not developing best practices. We're not moving forward with protocols and answers to how to stop those medical errors in the future. So from a quality perspective, we remove that barrier, we remove litigation, we start conversations, and just like pilots, we start talking about near misses in addition to those tragedies that happen. So actually you're improving the healthcare system if you eliminate litigation. Okay,
thank you. You know, I think about how much we currently spend on what we do, and I think about the conflicting instruction. I mean, we physicians, all healthcare providers, are instructed to, when there's a mistake or bad outcome, to quickly apologize and be honest and forthright with the patients. But those same people are also saying, don't get sued. And I don't know what a pithy similarity to that is, but it'd be kind of like if I was a big brother, so picking on my sisters. So I'm supposed to tell mom I've been picking on my sisters, knowing I'll get spanked if I do so. I don't see how that works. I'm motivated just to keep picking on them and be quiet. A lot of people have talked about a kind of non-litigation-driven response to adverse medical outcomes, which is kind of what we're talking about, that, you know, you would open the floodgates, and the very small number of people who have adverse outcomes who ever get compensated for it, well, what you're saying is we're now going to compensate all of them. Wouldn't that break the system?
Well, that's what's unique about the patient compensation system. And as you know, it is a workers' comp model for medical malpractice. So right now, you look at a typical medical malpractice dollar, and 23 cents of that dollar goes to the patient. Now, that patient then must turn around and compensate his or her attorney. So in actuality, that patient ends up with about 12.5 cents out of that litigation dollar. All of the rest of the money is going to defend a claim, which is about 30%, and medical malpractice insurer carriers profit, which is rather healthy. Hey, I'm a center-right Republican. I am all for profits, but some of the profits from this particular industry are astronomical. And as a consequence, patients are really taking it on the chin. Again, if you're designing a system to provide compensation for injured patients, we would not develop the tort system that we have today. It has disastrous impacts, not only on defensive medicine, not only on patient safety, but only 2 out of 8 Floridians who are legitimately injured by physicians or by facilities or by healthcare practitioners are ever compensated for their injury. And that's largely due to a business model that the trial bar has. And I'm not going to bash the business model, but it basically says if you don't have $300,000 to $500,000 of economic damages, you're not going to find a lawyer that's going to be able to take your case. As a consequence, those folks who are on the lower end of the economic scale, those folks on Medicare or Medicaid, simply can't retain an attorney to otherwise represent them. However, if you drive the waste out of the system, if you make it much more efficient, if you take care of that claim in 9 months rather than 7 years, if you don't collect the premium over that entire time while you're litigating that claim, while you have all of the perverse incentives that are brought into the impact of having a non-jury trial. Let's face it, in the current litigation system, patients don't have access to a judge and jury. Less than 1% of all cases go to a jury. In 2013, this is a kind of a sad statement of impact, but in 2013, 19 million Floridians paid $43 billion in defensive medicine so that 75 med-mal juries could be impaneled to compensate 18 patients. Now, Dr. Pigman, I know you're not a lawyer, but you are a policymaker, and if you were designing a system to take care of injured patients, that would not be the descriptive term that you would use for the system that we have today. So eliminating the tort system, creating an administrative solution that is driven by experts in specific fields. So if we've got an OBGYN case, you would have OBGYNs reviewing a redacted case file, no patient information, no doctor information, no city, no location, no hospital. It would just ask that panel of physicians, was this patient treated in a manner in which they suffered a medical injury? And if the answer to that question is yes, then compensate the patient. We've got 35, 40 years of clinical data. We know what folks are paying for wrong site surgeries, lap sponges being left in, wrong site knee surgeries. We know all of those facts. So pull those together, create an evidence-based, responsible schedule of payments so that we know we create a more predictable environment for insurers. And so, no, the floodgates, while the number of folks are going to go up, the overall cost is actually going to come down.
And if I caught what you said there, we're changing the standard necessary for the patient to prove or show in order to establish that there was an adverse medical event that's worthy of compensation.
That's exactly right. We're moving it from either negligence or gross negligence to was this injury avoidable? And that panel can look at all kinds of protocols, standards, national practice standards, to be able to help guide that panel in that one question, was this a medical injury? If we can throw up that second slide, we'll talk about the impact to the state of Florida, specifically as it relates to the state government, and specifically how it relates to private enterprise and private businesses. Can that slide kind of pop up? Ta-da. So $43 billion is being wasted on defensive medicine. Its impact to the public sector is about $15 billion. That's a 10-year cost study produced by an actuarial firm called Aon. That's $15 billion that can go back into the state coffer. I assume y'all have other issues, transportation, infrastructure, all kinds of things that your taxpayers could otherwise be doing with that $15 billion. But just as importantly, as business people in the room who are providing health coverage for your patients, for your employees, it's a huge impact. You can save somewhere between $30 and $60 billion over 10 years because you're not paying for unnecessary drugs, you're not paying for unnecessary scans or tests or procedures. The annual savings per employee is right in the $5,000 range. The annual savings on your premiums is somewhere between 10 and 22%, depends on who your carrier is. And most importantly, with the savings that could be generated from a patient compensation system, Florida employers could add 47 to 100,000 new jobs. And while we may be in the middle of some type of recovery, adding that kind of workforce advancements, I think is a pretty significant advantage to adopting this type of a system.
Thank you, Wayne. And for the record, I'm a Republican too, and I believe in profit, except when it drives consumer costs for no good reason and depletes states' general revenues. Then I get a little bit prickly. Let's come back to you, Stephanie. You've already touched upon it, but when you think from your world, the pharmaceutical world, when you think of the hidden costs that are currently there, what is the biggest one that you'd like to see us tackle? And is it more a individual consumer behavior where maybe education or appropriate incentives work? Or is it driven by statute or policy where it really needs someone like me to put a bill in place and to run it?
Perhaps I think the biggest area to maybe tackle is the at the point in care where the product is decided for that patient course of therapy. So, the first line agent that's chosen for a patient for a new or existing diagnosis, perfect case is when a patient is going from one benefit to the other and is needing to change or alter, the drug that perhaps they're on. We see a lot of times where patients may be just fine and controlled on a particular therapy, and then when they change benefits, they're having to go into something completely different. And in some cases, their health status may degrade, and it may be that they have to realize that degradation in order to go on to the next therapy. Another area that we see often, especially with specialty pharmacy, is patient utilization of products. So maybe not understanding how to utilize the medication, not understanding the impact of a missed dose. Perfect example, hepatitis C, you got a $1,000 a day pill the patient has to take, not understanding that pill, if you lose it on the floor, it costs $1,000. So providing patients with that education and enforcing adherence, those are probably the two areas that we encounter the most.
Lori, same question to you. Coming from the anesthesia perspective, and probably even more hospital-based, what do you see as the biggest hidden cost? And I think we know the answer to this. Is it consumer practice habit, or is it more policy statute driven?
I think it's more, from what we know, we have evidence that the policy driven costs are tremendous. And the hidden cost, I've already talked about the subsidies, but we didn't talk very much about the administrative costs. And how supervision looks in the state of Florida is an advanced practice nurse must file a protocol with the state for every practice arrangement, and it lists every physician that supervises you, and it has to be filed yearly. And if there's any change in the practice, for instance, a new physician joins the group, it needs to be updated within 30 days. A large anesthesia group may have an entire department just handling the administrative costs of filing these protocols. And the consequences, if you don't file the protocols, are a hit to your license. So you take it very seriously, these protocols. Removing supervision from the language in state statute immediately gets rid of protocols. So that's dollars that immediately go back to the patient care side of things. And let's be clear, removal of supervision does not mean, it's not an expansion of scope of practice in any shape. We'll do the same things that we've always done. I've always provided an anesthetic to a patient. It's not an expansion. It's just removal of layers of redundancy in state law, and it opens up and allows the facilities to decide for themselves what level of supervision makes sense for that particular facility.
Oh, and Lori, use that scope word, that four-letter word. Well, close. Wayne, I think we know the answer to your question, but go ahead and close it, then I'll come out to the audience. We'll ask some questions. What's the biggest hidden cost, statute or practice?
Well, I believe it's statute. State law establishes tort liability. It's been around since the dawn of time. Unfortunately, medical practice has changed, business practice has changed. Just in my lifetime, for example, this city of Orlando has just exploded, and it's changed. However, the practice of defensive medicine has really been a reaction to state statute, which is if you have an injury, you've got to litigate to have that injury reviewed. It doesn't have to be that way. The rest of the world and every English-speaking country on the planet go with an administrative route to handle medical malpractice disputes. So I believe it's statute.
Okay, if we can bring the house lights up, and if I get a spare microphone, or did Senator Bean have his own? I wouldn't be surprised if he just carries one around. I'll come out in the audience and take questions. Now, I will point out, this is a little bit of self-promotion. I think I'm either sponsoring or co-sponsoring a bill for each one of you. So let's...
Funny how that worked out.
Better than a moon pie.